welcome to this eCancer virtual discussion on apalutamide and its use in non-metastatic castration-resistant prostate cancer. My name's Prof Payne. I'm a clinical oncologist at University College London Hospitals, and I would like to introduce my colleague, in fact.
Yes, hello, my name is Stéphane Oudard. I am a professor of oncology and chief of the Oncology Clinical and Translational Research Unit at Georges Pompidou Hospital in Paris, France.
Thank you so much. I'm really looking forward to our discussion today. And we have opinions from both sides of the channel, it would appear. So, non-metastatic castration-resistant prostate cancer. This is a relatively new term in prostate cancer, and it describes a situation for men with a rising PSA despite castrate levels of testosterone from ongoing ADT or orchidectomy, who have normal conventional imaging, so no metastasis on bone scan and CT scan. And I think that we would all agree that for this group of men, and especially for those with a PSA doubling time of less than 10 months, we have known that they are at a significantly increased risk of metastasis and death. But until recently, there were no approved treatments for this situation, which was incredibly frustrating for us as doctors, but even more so for our patients who would have to wait to either get symptoms or have repeated scans to find metastasis, at which point they could have one of the many drugs for for metastatic CRPC. So non-metastatic CRPC, an unmet need, but recently we've had data from 3 studies showing an improvement in both progression-free and overall survival, which I think is changing our practice considerably. Today, we're going to be thinking about apalutamide and talking about 2 abstracts which are being presented at virtual ESMO. The first is looking at apalutamide for non-metastatic CRPC and comparing data from a real-world named patient program to that of a phase 3 randomized controlled study, the SPARTAN trial. We all know that randomized controlled trials are the robust reference standard in which we have new drugs available. But I think real-world evidence is becoming more important to see how the data that we get from clinical studies translates to our everyday practice. Stéphane, what do you think? Do you think real-world data, are we going to be seeing this more in the future?
Yes, well, first of all, I think that, the SPARTAN study, which is a phase 3 trial, a placebo-controlled study evaluating the addition of APA or placebo to ongoing androgen deprivation study, was reported and published in the New England Journal of Medicine. More than 1,200 patients randomized 2-to-1 to apalutamide or placebo plus ADT. Just to remind you that those patients were stratified by PSA doubling time, use of bone sparing agent, and nodal disease at study entry. And as you say, the primary endpoint for this study, MFS, was positive, outstanding, I would say, in favor of apalutamide plus ADT. And now we have this real-life study looking at, in daily practice, in real life, whether or not patients do benefit from apalutamide with ADT.
Absolutely. And I mean, I think some of these real-world studies give us a little bit more information because they include groups of patients that perhaps wouldn't be eligible for a clinical trial. But obviously, there is a lack of quality control in real-world evidence, and there's no regular radiology review, and it can be susceptible to bias.
That's true. In real life, you are not obliged to perform a CT scan, bone scan every 3 months, for instance, like in the SPARTAN study. So that's why, in this named patient program, they compare time on apalutamide instead of time to progression to see in real life for how long the patient was on apalutamide until progression. So it's interesting to have this endpoint to see if the patient can be maintained on treatment for a long period of time without toxicity and with efficacy.
Do you think that's a good proxy for time to progression in Do you think that was a reasonable endpoint to be looking at in this comparison?
I think in real life you need to use not time to progression because from one investigator to another, he may perform CT scan at different time. So that's why you can't just rely on time to progression. So I think that time on apalutamide is better because this is correspond to the real life for patient and clinician.
Thank you. No, I completely agree. And this is what happens in everyday practice. So the named patient program started in March 2018. It involved 536 men in 34 countries, and these included Germany, Italy, Ireland, and the UK. The data was based on comparison of initial follow-up at 10 months in both cohorts. And when we compare, because you often hear that argument that these patients don't exist in real life, but they do. They were put into this program, they were put into SPARTAN. And in the named patient program, it was actually very similar to the patients in SPARTAN. Median age was 74. Both studies included men in their 90s. There were slightly more men over 80 in the NPP, and slightly less men with a PSA doubling time of less than 6 months. Stéphane, I know this is difficult because you know the answer to the study, but would you have anticipated that we would see similar results in the NPP that we did in SPARTAN?
Yes, I think so, and I think that maybe the endpoint of looking at 10 months, the outcome of the study is maybe too short, if you want to just, to criticize this study. But I think, this is due to the fact that the study is quite, was performed in March 2019, and we need maybe more follow-up because, as you know, for apalutamide, the MFS is quite very long, and maybe we will have, better results, in case of mature data in the real life. But nevertheless, as you can see, and you just mentioned about that the patient characteristics were maybe the same, maybe a little older, because in real life, you may allow to prescribe this drug for any kind of patient without or with comorbidity and so on. So that's why maybe we have more elderly patient population, but we will see at the end that in fact the efficacy is the same.
I think that, this study does show that the data confirms that the results from SPARTAN translate very well into everyday practice. And the results of the study showed that more men remained on apalutamide at this 10-month period. The reasons for discontinuation in both studies were investigator-assessed progression, adverse events, or withdrawal by patient. And there was a difference in adverse events. There were more in SPARTAN than the NPP. Does that surprise you?
I would say yes and no. I think that's yes, because with this drug, ADT and hormonal have some side effect, but and no, because now investigator and clinician know how to handle this drug and how to prevent side effects, fatigue, hypertension, cutaneous problem, and so on. So they know how to modify, to decrease the dose, to use supportive care for the patient. So and we know that when you use a drug, at the end you have the experience of side effect and how to manage them in daily practice.
I think that's absolutely true, and certainly from personal experience, I found this to be a really well-tolerated drug, and my patients have done extremely well. There were no new safety signals identified in the NPP, which is obviously very good news. The patients who were older, certainly more over 75 as opposed to under 65, had more risk of earlier discontinuation. Again, does that surprise you in any way?
I would say no, because in the SPARTAN study, it was found that a younger patient may benefit the most from apalutamide plus ADT as compared to elderly patient population. So this is just a confirmation of the SPARTAN study that maybe this is due to another, I don't know, maybe comorbidity or the problem that the patient may face. So but you know, it's very, very few patients, so it's not a huge category of patient. So, you know.
And we want to give this opportunity to all our men, don't we, really? I mean, I got very excited at ASCO this year when we saw the overall survival benefits in these studies. And do you think that's going to change practice? Do you think the data from the real world is going to change practice, make us look for these patients and treat them earlier?
I think so for two reasons. The first one is that we have outstanding data regarding MFS and now OS. And as you know, they also look at those patients who do not receive, you know, APA, you know, later on, in terms of no crossover, I would say. And they found out that the difference in terms of OS is huge regarding this no crossover. So it means that you can use this drug or hormonal therapy much earlier on. You don't have any cross-resistance regarding the second hormonal therapy that you give to the patient later on. I'm speaking about PFS2. So based on these two factors, OS and PFS2, I think that we are going to use this drug much earlier on.
I completely agree. A 14-month difference in overall survival is really compelling. And we've now seen that this is the same in everyday practice in the real world. And the study demonstrating a trend towards improved rates of apalutamide continuation after the first 10 months, no new safety signals, and it's been well tolerated and shown similar efficacy in real world practice. Now on to the second abstract, which is looking at quality of life, health-related quality of life. And this is longer-term follow-up of quality of life from the SPARTAN study. And I think that obviously we're giving men a longer life expectancy, but we want that to be a good life. Can I ask you, how did you measure quality of life in the SPARTAN study?
Well, in the SPARTAN study, quality of life was evaluated using the FACT-P and EQ-5D questionnaire. At the beginning of the study, every month, and then every 2 months, and every 4 months post-progression up to 1 year. As you know, each treatment cycle was 28 days. And based on that, it was, possible to find out that there is no difference of quality of life until, I would say, the cycle 11, and at cycle 21 and 25, you have you begin to have a pronounced and statistically significant difference between APA and placebo plus ADT.
And you might anticipate that with longer exposure to a drug, that quality of life would change. What was the difference between apalutamide and placebo in the longer term?
In the longer term, you don't have any chronic side effect or side effect which impact on quality of life, and the quality of life is maintained. And in this study, we asked to the patient, well, first of all, I am bothered by side effect of treatment, yes or no? And it was no, mainly for the patient on apalutamide. And the second question was, may I have a lack of energy, yes or no, based on the fatigue due to these treatments. And it was not more reported in the apalutamide plus ADT compared to placebo plus ADT. So it means that apalutamide do not add any new side effects impacting on quality of life in daily practice.
I mean, this is really important, isn't it? Especially for men who have no side effects at the beginning, and the fact that for the men on placebo, their quality of life declined after 1 year. And I think that this, again, is going to have a big impact on the way that we use these drugs in the future, because they are well tolerated. I think it's important to also mention that there have been 2 other studies that have shown very similar results. As I said at the beginning, darolutamide in the ARAMIS study, enzalutamide in the PROSPER study. But today we've given you some updates on apalutamide. We could talk all day, but I guess we all have other things that we need to do. So thank you very much for joining us today and for your attention. We've really enjoyed the discussion, which I'm sure we'll carry on afterwards. Please stay well and safe in these difficult times, and we look forward to seeing you again in the very near future. Thank you.